Hello, my name is Dr. Jessica Cronce, and I'm an associate professor in the Department of Counseling Psychology and Human Services at the University of Oregon. I'm going to share with you a little bit about alcohol prevention. So, why should we focus on prevention? Excessive alcohol use is the leading cause of preventable death in the United States. Over 95,000 deaths per year are directly attributable to excessive alcohol use. And at an average of 29 years shorter lifespan per person, this adds up to 2.8 million years of potential life lost each year. Some of the conditions that are attributed to excessive alcohol use are various cancers, such as esophageal cancer, and organ diseases, such as liver disease. Additionally, traffic fatalities, drownings, accidental poisonings are also directly attributable to excessive alcohol use. And a small percentage of deaths are associated with alcohol poisoning or consuming enough alcohol where your respiration and heart rate slow to the point of stopping. Beyond these lost lives, alcohol has multiple impacts on individuals, such as injuries, sleep disruption, which itself can impair health or affect mental health, alcohol use disorder, as well as driving negative mood, can exacerbate other psychological disorders such as post-traumatic stress disorder, and alcohol use is implicated in a number of suicide attempts and completed suicides each year. All told, this costs the United States $249 billion per year from increased healthcare utilization, as well as other economic impacts such as lost workplace productivity. And all of these things constrain our social resources. So prevention is essential to save lives, to improve the quality of life of individuals, to improve their health, as well as to preserve our social resources. So when should we focus on prevention? Well, we know from available data that alcohol use increases across the lifespan, typically beginning in early adolescence and childhood. So you can see here that I've presented data from 8th grade all the way up to age 30 from a single study that followed individuals over time. And whether we're looking at lifetime alcohol consumption, which is the top blue line, annual alcohol consumption, which is the orange line, past 30-day alcohol consumption, which is that middle yellow line, daily drinking, which is the bottom green line, or various indices of heavier drinking, often referred to as heavy episodic drinking, which is 5 or more drinks in a row, 10 or more drinks in a row, or 15 more drinks in a row. You can see that all of these tend to increase over this period. In particular, we can notice between 8th grade and 12th grade that there is an increase with a steeper increase in the period from 12th grade to age 21, which in the United States, of course, is the minimum legal drinking age nationwide. After that point, you can see that while the rates still do go up a little bit, that it roughly plateaus after the minimum legal drinking age is reached. So we can think of prevention as something we need to focus on over the entire lifespan, but should begin relatively early in order to prevent more harms. So what are we trying to prevent when we talk about alcohol prevention? Well, first and foremost, we're trying to prevent negative consequences or alcohol-related harms. And these harms can be to the individual who consumes alcohol and to the individuals in their lives or around them. And these are often referred to as secondary effects. So reducing harms associated with interpersonal and sexual violence that occurs in the context of alcohol use, reducing traffic injuries and fatalities to passengers and other drivers who themselves did not consume alcohol, reducing disruption caused by alcohol. So for example, someone coming into a communal living situation who's making a lot of noise, who may be disrupting other people's sleep, who may be making spaces unusable for others, that type of disruption, as well as property damage. All of those are secondary effects and are sometimes a target of prevention for communities. Of course, in order to prevent alcohol-related harms, we're also trying to target alcohol use itself. And here we might think about preventing or postponing initiation of drinking, especially if we're having a prevention strategy we're applying to younger children or adolescents, preventing progression to higher risk drinking for those individuals who've made the choice to drink, which could include supporting a return to abstinence, because abstinence is always the lowest risk option, or reducing a pattern of higher risk drinking / promoting moderate to lower risk patterns of drinking. So we're trying to maybe not necessarily get a person back to the point of abstinence if that's not what they're willing to do, but to at least help them reduce the higher risk pattern of drinking. Now, typically, we don't target these things directly. Instead, what we need to target are the risk and protective and resilience factors that shape alcohol use. So we're always trying to reduce the risk factors and increase the protective and resilience factors. And these different risk and resilience factors vary by age, vary by group and community. And so it's very essential, as I'll talk about in a moment, that you assess what are the risk and resilience factors relevant to the groups with which you want to engage in prevention. So where do we focus prevention? Well, we can focus on the individuals who's consuming alcohol, right? We can try to intervene in their psychology or biology by changing beliefs, changing behavior, or in some cases, medication. Now, people often think medication is for treatment only. However, at least in young adults, some recent prevention approaches have offered combining behavioral techniques, changing beliefs and behaviors, with medication that dulls the pleasurable effect of alcohol to try to reduce that higher risk drinking. These are all individual focused strategies. But of course, individuals live in the world, and that is all a broader drinking environment or context. And so we have to also focus on how do we intervene in that drinking environment. And these environmental focused strategies really are aimed at changing those contextual factors that promote alcohol use and higher risk drinking. These include things such as the price of alcohol or the taxes that are paid when purchasing alcohol, the availability of alcohol, such as outlet density relative to where the person lives, the legality of alcohol consumption, so again, the minimum legal drinking age, as well as enforcement of that minimum legal drinking age, and other things such as host or server accountability and liability. So both of these are important areas of focus. And as we think specifically about the drinking environment, there's different ways that we could focus there. The Center for Disease Control and Prevention, or the CDC, has put forth a social ecological model. So the individual is at the center, but that individual is embedded within the context of various relationships. So family members, friends, peers, partners. And of course, those relationships happen in the context of communities. And this might be thought of as the direct context that the person lives in, their school, college, workplace, or neighborhood. But of course, each community is embedded within the larger social fabric, the indirect context, which is shaped by cultural norms for behavior, as well as policies and laws. As mentioned previously, the minimum legal drinking age, right? That is an indirect policy or law that impacts all of the different levels. So for whom should prevention be implemented? Now, we might think we should focus only on those individuals who are drinking in higher risk ways that place them at greater risk for consequences. However, the majority of the total alcohol-related harms are actually experienced by those drinking in lower or moderate risk ways, and also those individuals who are not drinking at all who are experiencing those secondary effects. Even though it is true that individuals drinking in higher risk ways typically experience more alcohol-related harms at an individual level. But if we think about each of these circles as an individual who is drinking and experiencing consequences, and the number in that circle is the total number of consequences that they've experienced related to alcohol use, you can see, even though those drinking in lower risk ways are experiencing fewer consequences individually than those who are drinking in higher risk ways, if you sum all of these up, the total is greater. So the takeaway message really is that prevention is for everyone, that we should be implementing prevention on the full spectrum from those who are abstaining all the way up to those who are engaged in higher risk drinking. So how should prevention be implemented? Imagine each of these gray dots is an individual who is consuming alcohol in a higher risk way. Well, certainly universal prevention is appropriate. This will impact these individuals engaged in higher risk drinking, as well as those engaged in lower or moderate risk drinking and those who are abstaining. Universal prevention applies to everyone in a population. Again, this could be enforcement of minimum legal drinking age or alcohol taxes, just as a couple examples. But it's also important to identify groups that are at greater risk for alcohol-related harm and to apply another layer of prevention. This is called selective prevention. So an example of a selective prevention strategy is personalized feedback that informs the individual about their drinking and their risks associated with that level of drinking, as well as strategies that they can use to mitigate those risks. Of course, not all individuals drinking in higher risk ways are in groups that are known to be at higher risk for drinking related consequences. And so universal screening is really important to identify those individuals who are engaged in higher risk drinking and provide them with a more specific personalized intervention. And this is often referred to as indicated prevention for the individual who's engaged in that behavior. An example of an indicated prevention program is brief motivational interventions. And that takes the personalized feedback that I described for selective interventions and uses that to facilitate a discussion with a trained provider who can help to increase motivation to change drinking behaviors. So although there are several different effective prevention strategies, I think it's helpful to think about what are some of the components that they share that makes them effective. Most importantly, I want you to take away that alcohol education alone is not an effective prevention strategy. A wealth of research has shown that to be true. So you can't take this one little piece of alcohol education and separate it out and have that make a difference. It changes knowledge, but it does not change drinking behavior and therefore does not impact alcohol-related harm. However, alcohol education is still an essential part of the overall puzzle because alcohol education is critical to effective use of skills to reduce the likelihood of harm. So skills, alcohol education, motivation, and self-efficacy can be thought of the building blocks that are present in most effective prevention programs. One way of thinking about this is it isn't enough to know what to do and when and how to do it. You also have to want to do it, that motivation, and believe that you're capable. And that's what we mean by self-efficacy. So if you know what to do, when and how to do it, want to do it, and believe you can do it, that is a recipe for an effective prevention strategy. One thing to help if you are trying to implement prevention in your community is SAMHSA's 5-step strategic prevention framework. This begins with assessment, identifying the local prevention needs and resources. So what are the needs in your specific community and what resources are available to target those needs? Next is building capacity. So increasing the community resources and readiness to address the prevention needs you identified in that assessment step. Planning comes next. This is where you should consult available repositories of evidence-based prevention strategies and identify ones that will match the resources that are available to you in your community. And then plan how to deploy those resources when you take the next step, which is to implement, actually apply the strategies to the population to see if you impact the needs that you identified. And that is the last step, which is evaluation. So you really want to assess how well did the strategy we applied change the things we wanted it to change? How well did it decrease drinking? How well did it decrease harms? And then ideally, what you want to be able to do is share those outcomes with other communities so they can learn from your experiences. Of course, central to all 5 of these steps are overarching principles of cultural competence and sustainability. It's essential when engaging in prevention to take into account the cultural context for that prevention and the different groups you're intervening with to be able to interact effectively across domains of difference, and to have an eye towards the long-term impact of what you're doing. So a good place to start, if you're not sure, in addition to the SAMHSA's strategic framework, is the U.S. Surgeon General's report, Facing Addiction in America, the Surgeon General's report on alcohol, drugs, and health, which was published in 2016. This report includes several registries of evidence-based strategies, so it's a good place to start in terms of finding other resources, in addition to the Surgeon General's earlier report on underage drinking. With that, I'd like to thank the Research Society on Alcoholism for having me make this video. I would encourage you to check out their website as well. There are additional resources there that may be of benefit. And I certainly would encourage you to go to the National Institute on Alcohol Abuse and Alcoholism's website for additional resources.